You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about apolipoproteins and Lp(a), as well as the familial dyslipidemias. I think it's a very important episode to understand because apolipoproteins and Lp(a) are more than just a lab test that we order. To fully understand apolipoproteins and Lp(a), we need to understand the entire cycle starting from chylomicrons. What are lipoproteins? Lipoproteins are spherical particles with a core and a surface. Core is composed mainly of triglycerides and cholesterol esters that are hydrophobic lipids. The surface is made of phospholipids, free cholesterol, and apolipoproteins. The apolipoprotein components of lipoproteins are important for structural support, recognition by receptors throughout the body, and in some cases, enzymatic activity. What are the main apolipoproteins? There's apolipoprotein B, short form is ApoB. ApoB100 is present on VLDL, IDL, LDL, and Lp(a) and is synthesized in the liver. ApoB48 is present on chylomicrons, synthesized in the intestines. The two main forms of apoprotein B, ApoB48 and ApoB100, actually arise from a single gene, not two genes, that has a unique editing mechanism that allows for synthesis of two different proteins. Then you have apolipoprotein A1 or ApoA1, which is present on HDL and to a lesser extent chylomicrons. ApoA1 plays a central role in reverse cholesterol transport, helping HDL remove cholesterol from tissues and return it to the liver. Higher levels of ApoA1, which is the major apolipoprotein of HDL, are correlated with lower angiographic coronary artery disease. Circulating ApoA1 interacts with the ABCA1 transporter on peripheral cell membranes that initiates lipidation of HDL particles. ApoA1 also activates the plasma enzyme lecithin cholesterol acyltransferase, which esterifies free cholesterol, an important step in the reverse cholesterol transport pathway. Then you have apolipoprotein E, or ApoE for short, that's present on chylomicron remnants, VLDL, IDL, and HDL. ApoE mediates receptor recognition of chylomicron remnants and IDL by LDL receptors and remnant receptors for receptor-mediated endocytosis and subsequent clearance of chylomicron remnants and IDL by the liver. Those are the apolipoproteins, B100, B48, A1, and E. Now, what is lipoprotein a? Lp(a) is an LDL particle that has its ApoB100 component linked by a disulfide bridge to apolipoprotein a, or ApoA in brackets. This Lp(a) is overwhelmingly determined by genetic factors and is unchanged by diet and physical activity. Statins do not reduce Lp(a) levels, but PCSK9 inhibitors do. What's the usual pathway of transport? You start out with chylomicrons, which is 90% composed of triglycerides, and chylomicrons carry dietary triglycerides from the intestines and become chylomicron remnants after triglyceride removal, and it's cleared by the liver via apolipoprotein E assisted receptor-mediated endocytosis. Then you have VLDL, very low density lipoprotein, which are 60% composed of triglycerides. VLDL carries endogenous triglycerides from the liver. It loses triglycerides via lipoprotein lipase and becomes IDL, intermediate density lipoprotein, and then further loses triglyceride to become LDL, low density lipoprotein. LDL is 5% composed of triglyceride and 50% composed of cholesterol. LDL is the main cholesterol carrier. LDL delivers cholesterol to tissues and is cleared by LDL receptors via apolipoprotein B100 assisted receptor-mediated endocytosis. Then you have HDL, high-density lipoprotein, or quote, good cholesterol. 5% composed of triglycerides, 15% composed of cholesterol, and 50% composed of protein. So that's why HDL is high density. HDL picks up cholesterol from tissues as part of reverse cholesterol transport and returns it to the liver with the assistance of apolipoprotein A1. To summarize the information so far in a different way, the lipoproteins that are triglyceride rich are chylomicrons, which have 90% triglycerides, and very low density lipoprotein, which have 60% triglycerides. The lipoproteins that are cholesterol rich are LDL, which have 50% cholesterol, IDL, which is 25% cholesterol, and HDL, which is 15% cholesterol. The lipoproteins that carry one apolipoprotein B molecule each are VLDL, IDL, LDL, and Lp(a). Remember, Lp(a) is an LDL that has its ApoB100 component linked by a disulfide bridge to apolipoprotein(a). The lipoproteins that carry lots of apolipoprotein A1 is HDL, the main protein component for reverse cholesterol transport. Now, let's focus on Lp(a). Lp(a) level of more than 75 nanomoles per liter is elevated, and values of Lp(a) more than 125 nanomoles per liter increases the risk of ASCVD significantly. Why is it better to measure Lp(a) specifically in nanomoles per liter rather than milligrams per deciliter? Because Lp(a) particles vary in size due to the variable number of Kringle 4 repeats in the ApoA protein. Kringle refers to a specific structural motif found in certain proteins, characterized by a looped disulfide bonded structure resembling a pretzel or Danish pastry, which is where the name Kringle comes from. Larger Lpa particles contain less cholesterol and protein per particle, whereas smaller Lp(a) particles contain more cholesterol and protein. The particle count in nanomoles per liter is more relevant to atherosclerosis risk because the atherogenicity of Lp(a) is related to the number of particles, not their mass. Nanomoles per liter measures the number of Lp(a) particles, whereas milligrams per deciliter measures the mass of the Lp(a) cholesterol and protein content. Milligrams per deciliter, on the other hand, does not differentiate between small, dense, and more atherogenic Lp(a) particles and larger particles, potentially underestimating risk in individuals with small Lp(a) particles. Because nanomoles per liter accounts for the variability in particle size, it provides a more accurate reflection of cardiovascular risk. Apolipoprotein(a) shares sequence homology with plasminogen, so Lp(a) can inhibit endogenous fibrinolysis by competing with plasminogen for binding at the endothelial surface, thus increasing the risk of thrombosis. Now, what about ApoB? ApoB provides an integrated measure of VLDL, IDL, LDL, and Lp(a). Remember, one on each. Whereas LDL cholesterol, our traditional measure, measures only cholesterol within LDL particles. Apolipoprotein B is a better predictor of cardiovascular risk than LDL cholesterol itself because apolipoprotein B directly measures the number of atherogenic particles, including small dense LDL, which are more atherogenic than large LDL particles. Elevated ApoB levels correlate with a higher risk of ASCVD and may identify risk even when LDL cholesterol levels are normal, particularly in patients with a metabolic syndrome or diabetes. ApoB is especially useful in patients with discordant lipid profiles where LDL cholesterol might underestimate risk, for example, patients with high triglycerides, insulin resistance, or small dense LDL particles. In patients with hypertriglyceridemia, ApoB is often elevated, even if LDL cholesterol is normal, because of the increased number of VLDL and LDL particles. An optimal level of ApoB is less than 90 mg per dil for low to moderate risk individuals and less than 70 mg per dil for high risk individuals. International guidelines differ on who exactly should get testing for Lp(a) and ApoB. And at the time of recording in 2024, the AHA-ACC has not put out a guideline recommendation on who to send this testing for. However, for practical purposes, common threads among international recommendations are as follows. Order Lp(a) testing when you have patients with a family history of premature ASCVD, because Lp(a) is highly genetically determined and not dietary determined. And elevated levels of Lp(a) are a strong risk factor for MI and stroke at an early age. Also, order Lp(a) testing in patients with a personal history of premature ASCVD, especially in those without typical risk factors such as absence of metabolic syndrome, no smoking, and regular exercise. Consider Lp(a) in patients with unexplained recurrent ASCVD events despite seemingly low or optimized LDL cholesterol. Also consider it in patients with calcific aortic valve disease, since there is a positive association between elevated Lp(a) and CAVD. And lastly, in first-degree family members of individuals who have elevated Lp(a). Now, what about ApoB testing? Consider ordering ApoB testing in patients with hypertriglyceridemia, more than 150 mg per dil, because LDL cholesterol does not properly count VLDL. Remember, VLDL is 60% composed of triglycerides, and small dense LDL, which are better accounted for by ApoB levels. In patients with metabolic syndrome, or obesity, or type 2 diabetes, you should consider ApoB testing, as these patients often have higher levels of small dense LDL particles and VLDL, which may not be fully captured by LDL cholesterol measurements. Consider ApoB testing also in patients with discordant LDL cholesterol and non-HDL cholesterol levels, where non-HDL cholesterol is high but LDL cholesterol is normal. ApoB can measure a fuller range of the atherogenic particles. Consider ApoB testing in patients with suspected or diagnosed familial hypercholesterolemias, and in patients with recurrent ASCVD events but normal or borderline LDL cholesterol. ApoB can reveal a hidden risk due to a high number of atherogenic particles that are not being measured. That wraps up the first half of this episode on Lp(a) and apolipoproteins. Now we'll move on to the familial dyslipidemias, starting with familial hypercholesterolemia. Familial hypercholesterolemia, or FH, is an autosomal codominant disorder that results from defects in a gene encoding the LDL receptor. More than 1,000 different mutations of the LDL receptor gene have been identified. Homozygous FH is very rare, occurring in 1 in 1 million, and have virtually no LDL receptors. In contrast, heterozygous FH occurs in 1 in 500 individuals. FH causes LDL levels greater than the 95th percentile. 7% of American adults have plasma LDL levels of 190 mg per dil or higher, but fewer than 2% of such individuals will have a familial hypercholesterolemia mutation. Physical exam of FH heterozygotes or homozygotes will show corneal arcus, which are deposits of cholesterol within the cornea, xanthelasmas, which are deposits of cholesterol on the eyelid, tendinous xanthomas of the Achilles tendon, and various extensor tendons of the forearm and leg, resulting from deposits of cholesterol derived from LDL particles. In addition, FH homozygotes have a unique cutaneous finding called planar xanthomas. Planar xanthomas are yellow to bright orange spots that are in areas of trauma on the knees, elbows, and buttocks, as well as in the interdigital webs of the hands, especially between the thumb and finger. The presence of FH can be verified by assaying the density of functional LDL receptors on circulating lymphocytes or genetic testing. Men with heterozygous FH usually develop CAD in their 20s or 30s, while women with heterozygous FH usually develop CAD in their 30s or 40s. That's familial hypercholesterolemia. Briefly, we'll talk about familial defective apolipoprotein B and familial combined hyperlipidemia. Familial defective apolipoprotein B, which results from mutations in the ApoB gene, cause a reduced affinity of LDL particles for their LDL receptor and is clinically indistinguishable from familial hypercholesterolemia that we just talked about. Familial combined hyperlipidemia, or FCH, is a common polygenic condition involving elevation of LDL and or triglycerides, elevation in ApoB, and reduction in HDL. FCH will usually not have corneal arcus or xanthomas. Next, we have dysbetalipoproteinemia. Broad beta disease, also known as dysbetalipoproteinemia or type 3 hyperlipoproteinemia, results from mutations in apoprotein E, which is found in VLDL, IDL, and chylomicrons. Patients with broad beta disease will have premature atherosclerosis and elevated total cholesterol and triglycerides due to an increase in IDL and VLDL. This beta lipoproteinemia is characterized by two dermatologic lesions: xanthoma striatum palmare, which are orange or yellow discolorations of the palmar and digital creases, and tuberoeruptive xanthomas on the elbows and knees. That's this beta lipoproteinemia or broad beta disease. Then we have familial hypertriglyceridemia, also known as type 4 hyperlipoproteinemia. It is a polygenic disorder with elevated triglycerides, but normal or low LDL and low HDL. The prevalence of familial hypertriglyceridemia is 1 in 100 to 1 in 50. It is genetically heterogeneous in that there is no consistent abnormality in lipoprotein structure or receptor function. The hypertriglyceridemia of familial hypertriglyceridemia usually does not appear until puberty or early adulthood, at which time they are moderately elevated, around 200 to 500 mg per dil. Hypertriglyceride exacerbations with plasma triglyceride levels as high as 1000 mg per dil can be precipitated by excessive alcohol ingestion, poorly controlled diabetes, use of birth control pills containing estrogen, hyperthyroidism, or even after a meal. The hypertriglyceride exacerbations manifest as pancreatitis and eruptive xanthomas. Individuals with familial hypertriglyceridemia should restrict the intake of fats and alcohol and avoid obesity if possible. Surprisingly, familial hypertriglyceridemia does not actually come with an increased incidence of atherosclerosis. It is unclear whether the protective effect is due to accompanying decreases in HDL cholesterol. Next, we have hyperhomocystinemia. Homocysteine is an amino acid derived from demethylation of methionine from the diet. Homocystinemia and homocystinuria arise from disorders of methionine metabolism, most commonly cystathione beta synthase deficiency. Patients with cystathione beta synthase deficiency and consequent hyperhomocystinemia present with MI as early as the first decade of life. Mild to moderate elevations in homocysteine unrelated to inherited deficiencies of methionine metabolism are common in the general population due to insufficient dietary intake of folate, use of folate antagonists such as methotrexate, hypothyroidism, or renal insufficiency. Folic acid supplementation can decrease homocysteine levels, especially when B12 supplementation is also given. However, the reduction in plasma homocysteine level from B12 and B9 supplementation does not seem to translate into a reduction in atherothrombotic events. Finally, we'll go over drug-related hyperlipidemia. Do not forget secondary medication causes of hyperlipidemia. Diuretics and amiodarone raise LDL. Beta blockers raise triglycerides and lower HDL. Thiazides raise triglycerides. Retinoic acid and glucocorticoids raise both LDL and triglycerides. Pregnancy and hypothyroidism will elevate both LDL and triglycerides. Estrogen replacement therapy raises HDL and triglycerides. Protease inhibitors for HIV raise triglycerides and total cholesterol and reduce HDL. Second-generation antipsychotic medications such as clozapine and olanzapine cause weight gain, insulin resistance, and increased triglycerides and LDL. Corticosteroids increase triglycerides and lower HDL. Cardiovascular drugs that have no significant effect on plasma lipoproteins are calcium channel blockers, ACE inhibitors, and ARBs. Alcohol, which does not affect LDL levels, increases HDL levels and also reduces platelet aggregation. Also, remember secondary comorbidity causes of hyperlipidemia. Biliary obstruction increases LDL. Nephrotic syndrome increases both LDL and triglycerides, and CKD increases triglycerides. That's all for apolipoproteins and Lp(a) and the familial dyslipidemias.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.